Welcome back to part 2 of the New Zealand Adult Asthma Guidelines. My name is Richard Beasley, and I'd like to take up where we left off with the previous presentation with the strategy, the step up and step down strategy for the management of asthma. The guidelines are very clear that the preferred way to implement this management strategy is through the use of an asthma self-management plan, also known as action plans. And it mentions that the real skill in terms of the implementation of the plan is the amount of detail that's provided, which particular plan is used, and how you negotiate and educate the patient to ensure that they're familiar with the instructions, are confident in its use. And so the guidelines have put forward 3 different formats for the management plans that might be suited for different patients. So I'd like to briefly show you the 3 templates that have been provided as part of the asthma guidelines. This first one is the standard 3-stage management plan, which is suitable for patients either on inhaled corticosteroids as maintenance or ICS-LABA combination therapy as maintenance, together with a short-acting beta-agonist as reliever therapy. So the 3 levels of asthma control are identified by the patient in accordance to changes in symptoms, and the option is provided that changes in peak flow rate may also be provided to the patient. There's the level at which severe asthma is recognised, and the patient may have the opportunity to take a predetermined course of prednisone, and also instructions of what to do in an emergency in terms of seeking emergency medical care. If we turn now to the 4-stage asthma self-management plan, which has that additional stage where a patient recognises worsening asthma and has the opportunity to increase the dose of their inhaled corticosteroid, which is achieved by increasing its use from 2 to 4 times a day. And this has been shown in management plans to lead to an improvement in asthma outcomes, probably due to a behavioural change in terms of increasing compliance with inhaled corticosteroid therapy, particularly when the patient is more symptomatic. And of course there needs to be a separate plan for the SMART regimen, which can only be used with the budesonide formoterol Symbicort Turbuhaler, for it's only this product that has approval for use of the SMART regimen in New Zealand. And so this is a very similar plan, but I think the key thing in terms of the implementation of this plan is to make it very clear that although the standard maintenance dose of Symbicort may be 2 puffs in the morning and 2 puffs in the evening, when it is used for reliever use, only 1 actuation is given at the time, and that is because the formoterol component of Symbicort is more potent than the standard short-acting beta-agonist, and for that reason you take 1 actuation rather than the standard 2 puffs of a short-acting beta-agonist drug. And of course for the emergency situation, that when one takes repeat doses of their reliever, that would be repeat doses of their Symbicort inhaler rather than a short-acting beta-agonist drugs. So across the 3 formats of the management plans, the basic structure is the same, although there's the ability to introduce different components or variances of the theme in terms of the particular plan which you may wish to use. And so the guidelines also provide a structure by which one might implement a management plan in terms of a standard consultation. And I think in some respects this schema can also be used in terms of structuring a clinical consultation with an adult asthmatic. And so one would start on the left with the assessment of asthma control through the ACT score. If possible, one would also undertake a measurement of lung function, and then assess risk, in particular through identifying whether there had been any recent severe exacerbations. The next step would be to consider other clinical issues that may be relevant to the patient. It is always important to assess compliance, inhaler technique, whether there are other clinical features of risk, and also whether one is going to incorporate peak flow monitoring in terms of their asthma self-management plan. The next step is to determine whether there's a requirement to step up or step down asthma treatment in accordance with the step up, step down strategy, and also if the patient has been identified to have been at risk of severe exacerbations, then whether one wants to transfer across to the SMART regime. And you would then move on to the implementation of the asthma self-management plan. And I think here it's really important to decide with the patient which plan to use. negotiate the detail in terms of the plan, in terms of whether you're going to use peak flow monitoring, at what cut points to designate different levels of severity, whether you're going to use the option of doubling up the dose of inhaled steroid for worsening asthma, and also in terms of a severe exacerbation, whether the patient is comfortable and familiar enough in terms of having a course of prednisone to start according to a predetermined plan. And so I think that while there may be other things that you might like to do in terms of an asthma consultation, this provides a framework of sort of the basic requirements that can be used with individual patients, and particularly with the implementation of an asthma self-management plan. So I'd now like to turn to this new concept of treatable traits, which has recently been proposed in a landmark publication in the European Respiratory Journal. The concept behind the treatable traits is that we need to recognise that in clinical practice, asthma is essentially a syndrome of overlapping different disorders. And for this reason, that the response to standard asthma management may well be different on occasions between the different disorders that make up the syndrome of asthma. And that this may require recognition of the different features that lead to the complexity of asthma that we see in clinical practice. And so that we need to consider whether there may be overlapping disorders, whether there may be comorbidities, environmental or behavioural factors that may lead to poor asthma control or different presentations or natural history of the disease. And that these treatable traits may need to be recognised and investigated and treated if we're going to get optimal control of a patient's respiratory health. And so the treatable traits approach really provides a standard way in which one can address these additional factors that may or may not be relevant to individual patients. So we have overlapping disorders. Does this patient, in addition to asthma, have features to suggest there's a dominant COPD component, and should we be going down the COPD treatment pathway as well? Does the patient have bronchiectasis that may require investigation and treatment in its own right? And in particular, do they have allergic bronchopulmonary aspergillosis? Or is one of the reasons for their poor symptom control because they have psychogenic breathlessness? And do we need to have specific investigations and treatment towards common disorders such as paradoxical vocal cord dysfunction? Do they have important comorbidities that need investigation and treatment in their own right? In particular, chronic rhinosinusitis. And if it is possible to well manage that component of their disease, will that lead to better overall control of their asthma as well? And we're all familiar with the how common anxiety and depression is in terms of patients with poorly controlled respiratory disease. So it's also important to consider environmental factors that may be leading to poor respiratory health, and we need to go beyond just smoking. In particular for asthma, we need to consider whether there may be an occupational basis for the disease, perhaps in patients who develop late onset adult asthma. And that in addition to occupational factors, it may be also important to recognise other provoking factors that may be modifiable that could lead to improved asthma control. And of course, we need to consider every time we see a patient whether they're compliant with their treatment and also whether they have a satisfactory inhaler technique. And so if we're going to achieve the optimal outcomes with our asthma patients, we need to not only have a standard approach to the assessment and management of asthma, but particularly for the patients who have poor asthma control, we must have the ability to try to go towards precision individualized medicine, where we recognize overlapping features, comorbidity, environmental and behavioral factors that may be contributing to their poor respiratory health and need to be investigated and managed in their own right. And so if we return now to the overall strategy for the management of asthma, the step up and step down approach, we can see that we have two components in terms of our asthma management. The first component is to step up and step down in accordance with changes of asthma control or risk of severe exacerbations with our standard approach to asthma management, and this would apply to all our patients. But on top of this, we can overlay an individualized, personalized management regime in which one considers overlapping conditions, comorbidities, environmental and behavioural factors that may also be relevant in contributing in particular to poor control with our asthmatic patients. And so we have both a standardised approach to the management of asthma overlaid on an individualised approach in terms of investigating and treating treatable traits that may be contributing to poor respiratory health in our asthmatic patients. And so I'd like to finish the presentation at this stage. In the third presentation and final part of the series, I will address the assessment and management of acute severe asthma.